All right, this is me, of course. My name is Tejas Shaker. I'm a rising third year medical student here at Rush. And today I'll be talking about portals. Specifically, my talk is titled Portals for Progress, Leveraging Digital Health to Empower Patients. So I want us to first anchor on this first word here, portals. When you think of portals, what do you think of? For a health literate audience like I have probably here today, we might already be thinking of patient portals. But if you're like myself, prior to entering medical care, this is what you might have thought of. Something like this, right? And while this is definitely comedic, there's definitely something to be said about this as well, and this disconnect between some of the terminology that we often use in medicine, as well as technology, and what that can mean for our patients. If we have this general conception of portals, especially as patients here, who might be using these patient portals, they might not understand what they're actually going to be utilizing. So it's a small caveat and a small note here to just be very intentional, and for us to, throughout this talk, to recognize that a lot of the terminology and jargon often that we use as medical professionals and people in tech definitely has a real impact in the quality of care that we can prescribe our patients. What is a patient portal? Well, it actually looks something like this, as you might be familiar with. Patient portals have a variety of functionality. They can allow us to view medical records, test results, appointments, billing and insurance. You get it. There's a ton of functionality baked in. And this is something that's great. And patient portals didn't necessarily always have this functionality. And if we think back to actually our medical records as well, they were initially a way for us to manage documentation and bookkeeping. But along the way, they evolved in functionality and evolved in the way that we can assist patients. But ultimately, in practice, patients aren't necessarily always reaping the benefits of these patient portals. So to better understand where we go from here, we need to actually take a step back and look at the history of how we got to patient portals by looking at the electronic health record that underpins and underlies these patient portals, as well as, even before that, maybe something like this, right? Paper records. So I can definitely hear a lot of chuckles in the audience, and if you're somebody who's been in the healthcare field long enough, you probably remember this, these walls and walls of patient records. And again, you can understand how electronic health records, as they've evolved, again, with that additional functionality, were initially designed to be a better bookkeeping system than this. There's a lot of admin burden that goes into maintaining this. You need physical infrastructure, you need staff, you have unreimbursed time that's effectively being taken away from patients that's going to be used to manage these paper records. So thankfully, now we've moved on from that for the large part. So this is where we're at today with electronic health records, which again, underlie these patient portals. And we'll dive into patient portals in a little bit more depth here. But again, just understanding that the electronic health record system has evolved from these paper records is critically important. And as of 2021, here in the US at least, 96% of non-federal hospitals, as well as 78% of clinics, utilize electronic health records. So definitely a step in the right direction, but as is a theme throughout this talk, you definitely have to think about who's potentially being left behind as we continue to progress on the technological front. So I want to take you back through briefly a history of EHRs. And I know this slide can seem daunting. We're not going to go through it in its entirety, but I want to first think about, even before EHRs and before they came to exist, we definitely needed to have the electronic infrastructure and the technological infrastructure as institutions to even allow for the development of EHRs. So back in the 60s is really where you saw this. Institutions like Mayo Clinic were some of the first to adapt these large electronic systems. And from there, in the 80s, we saw the rise of EHR systems in academic medical centers. And it should make sense that these happened in academic medical centers because they had the infrastructure to develop that innovation through that sector, as well as financial resources and the medical capacity to be able to test these early EHR models. So really we saw this a lot more in the academic medical centers. That's complemented, as you'll see with time, some public sector support in addition to the private sector developing this. So in the 90s, we of course had the internet. It facilitated the ability for integration and interoperability. And then before we get to that 2004 metric there, really in 1996, that's when we saw the development of HIPAA. And that became effective in 2003. And it allowed patients this paradigm shift of being able to have the right to view their medical record, as well as general protections around protected patient health or protected health information or PHI. Then in 2004, we had the US government initiate EHR standardization efforts, and together HIPAA as well as these EHR standardization efforts were critical in allowing for the development and rise of EHRs in its true form as we see today. In 2009, we had the HITECH Act, which allowed for financial incentives to be underpinning these EHR adoptions across institutions. And this was actually a very critical inflection point. We saw a lot of private practices drop out, for example, because they were unable to make that shift over to what their peer institutions were doing with using EHRs because of the efficiency and throughput that was increased as part of this. So this was really again, crucial inflection point that throughout the 2010s, we saw complementary development of EHR interoperability. As you may know, as potential healthcare professionals, trainees, and students, two of the biggest EHRs that are used here in the US are Epic and Cerner. And here at Rush Medical System, we use Epic. And the patient portal that we use is Epic MyChart. So in 2015, the Cures Act allowed for EHR access to really be prioritized again, another paradigm shift in complement with HIPAA. And this allowed and mandated for patients to be able to request not only their medical records, but to have them freely available through EHRs without delay. So this really put pressure on electronic health record systems to be able to have these patient records, both not only for access for physicians and providers, but as well for patients as well. And then finally in 2020s, we're seeing the rise of AI, ML, generative AI, and all these integration into EHRs as it might be for predictive health analytics, modeling, things like that. So a quick, concise, but still relatively lengthy history of EHRs, of course. But it's very important to understand this because as we're thinking about patient portals going forward, we need to know and be able to look back at the history of how we even got here. So thank you for humoring me in that. So now with actual EHRs, what were their functionalities? And through some of the language that I've already used so far, we can understand that they had multifaceted roles. But initially when they were first conceived, they really focused on a few things. They were meant to improve documentation, reduce medical errors, enhance provider communication, and centralize clinical information. And this was really great, especially between different systems as well as different practices. So that way you didn't have to necessarily use fax to send over different medical records for patients, especially in emergent situations where you didn't have the time to necessarily obtain some of those records. So these were some of the core functionalities that we saw EHRs initially. But then with time, as with all things technology as we've seen, we're now here. And we have these additional functionalities with patient engagement tools, being things like Epic MyChart with these portals, as well as clinical decision support, some of the drug-drug interactions that you might see within your electronic health record that it flags for you, or maybe if you misenter the medication dose, that's another example of a clinical decision support. And that also intertwines with data analytics and population health, as we'll see in the future, with some of that risk modeling when it comes to different patient populations, demographics, et cetera. We also see EHR interoperability, and that's been the focus of the 2010s as well. Telehealth integration is something that we especially saw during the pandemic and continues to be a veritable way to access medical care, as well as billing and revenue cycle integration. And this last point is actually very fascinating because initially, again, EHRs initially were meant to be a transition away from these paper records and just meant to be bookkeeping tools. But now what we've seen with ICD-10 codes as well as CPT codes, billing and revenue integration is inherent within the medical record. It's something that totally changes the way that we care for patients. We're so focused as well on the ways that we document some of the procedures that we do, potentially maximize billing per administrative burden that we have to uphold as medical professionals. All right. Yes. So, of course, we've been talking about EHRs, but this just goes to show that technology is proliferative in all domains of our life. And even preceding this kind of bulky handheld phone here in 1973, you can even think back to what we still have today, right? The US mail post office. We had landlines, and you were still physically tethered to a geographical location, maybe your kitchen or whatever it might be, but you were still in that area and you had to make your call and you couldn't migrate beyond that. So going forward, as you see, now we have technology at our fingertips. But again, kind of the through theme here is who does this potentially benefit and who potentially misses out on this, right? If we think about some of the older patients, within our nation, there are folks who don't necessarily know how to make that transition to smartphones and access the technology that we have, many of us have at our fingertips. So it's a key component of thinking about, even with patient portals and the proliferation of functionality, that there are still gaps in the way that we are able to care for patients, and it's proliferative across our lives too in relatively benign domains, or so we think. Going forward, I also want to mention that, again, thinking about the demographics of who potentially serves to benefit and who serves to lose, even the way that we are being educated nowadays has radically transformed as well. It's been a complete paradigm shift where 99% of my learning is essentially online and through a computer. And along the way, I've had to learn the tools and resources in order to be able to use these technological tools in order to pass my classes. And that can't be necessarily said the same of folks who are working a job, maybe manual labor or whatever it might be, who don't necessarily have to make that paradigm shift because they're not in education or they're not in a field that requires that mandate. And those people are also our patients. So again, there are provisional gaps with who actually is using these patient health records and the ways that they've been trained across their lifetime to interact with this technology as well, starting from as early as education. And it goes to show that digital literacy ultimately should be thought of as a modifiable social determinant of health, although a very stagnant one as well. And folks who don't necessarily even have the benefit of going through our educational system are often left behind and are often the ones who also have worse social determinants of health and lower socioeconomic status as well. So this is just another slide to demonstrate that, again, if you think about kind of the inflection point maybe around here, folks who have been growing up with technology used in their educational domains and whatnot, they are the ones, especially as you can see here, are a little bit more accustomed to potentially using this technology to use their electronic medical records and access that through patient portals. The folks who maybe are on this other end of the spectrum, they might not be so lucky because they haven't grown up with that technology and they weren't accustomed to the ways that it's changed over their lifetimes, and they weren't thought of as the primary end user in these processes. And these are ultimately some of society's most underserved and vulnerable folks as well. And all of this goes to show that and paint the picture that there is truly a digital divide, not when it just comes to technology as a whole, but even in the way that we interact and understand our own health. As of 2022, only 57% of US patients reported portal usage. And as you think, what went on during that time was COVID, right? So we definitely would have seen an uptake in the use of patient portals, of course, with kind of the remote nature of the pandemic, but also usage as many people were getting sick, even healthier individuals who weren't potentially sick before. So this is a pretty shocking statistic that is showing even across multiple domains of life, technology is definitely something that increases that digital divide, but as well, particularly with patient portals, we see that in the way that nowadays we are meant to access our healthcare, or the primary modality in which we do, we see a major gap there as well. So that's a lot, right? It's very heavy. But now, with that knowledge in mind, what are we actually doing about this? And I'm proud to say, definitely here at Rush, we emphasize that and take that to heart with that mission. And not promotional by any means, but in terms of what we've actually been doing on the grounds here, is we've developed this program here at Rush called Rush DHealth. And that stands for the Digital Health Equity and Literacy Program. And what we've actually done through Rush DHealth is we've been founded as a RICSIP. And I'm very proud to say that the infrastructure and scaffolding here at Rush allows for student-led, faculty-supported programming. And RICSIPs, if you're unfamiliar with the term, are Rush Community Service Initiative programs. And this infrastructure has been critically important in allowing us to actually make change in terms of teaching patients how to use their patient portals, as well as measurably improving their digital literacy. So I'll go into a little bit about our mission and our focus and everything like that. But I just wanted to highlight that truly this would not be possible without RICSIPs. And then Rush DHealth. So our mission is, again, recognizing that digital literacy is a modifiable social determinant of health. We want to teach patients materially how they can better enhance their understanding of their own health, as well as improve their digital literacy. So practically what this means for us, again, with Rush using the Epic system, we teach patients how to use Epic MyChart. So we go over some of the core functionalities of MyChart, we walk them through that process, we get them activated and set up here in the emergency department here at Rush University Medical Center, and we're able to actually teach patients and improve their knowledge of their digital literacy. And there are going to be major effects that we anticipate a downstream of that I'll go into, and how we hope we can track this progress and actually provide statistics and numbers on this. But in terms of our team, we're entirely student-led. So we're medical students, we're graduate students, we're even non-clinical students here at Rush, because ultimately what we're doing is education. We're not doing any sort of patient care, but we're finding this unmet need where it's nobody's responsibility to necessarily teach a patient how to use their patient portal. It's a gap currently that we are aiming to solve and to fix. So we have a pretty rigorous training process. We all undergo standardized training. We learn how to operate within the emergency department, who providers are, how to respect these ED workflows, as well as to actually approach patients and what it means to teach them about their digital literacy and how to recognize who eligible patients are. So we also have a wonderful volunteer schedule that's maintained by our steers of our organization as well, that allows us to actually facilitate this process and put it into action. So in terms of our workflow, what this actually means is we take a look at the ED census or tract board whenever we go into the emergency department. And from there, we're able to look at something called the ESI, or Emergency Severity Index. And basically this tells us whether patients are low acuity or high acuity. Because of course you have to think about, we want to minimize disruption to healthcare. And ultimately, we are best received if we're approaching patients who are there for low acuity issues, that we can teach them and they're not in pain or have other ailments going on that they aren't able to really focus and give their attention to, nor should we really be talking to them if they're in emergent crisis, right? So the ED census is critical for us to identify these patients. In addition, we only talk to patients who are adults, 18 or plus, or 18 years or older, as well as who don't have psychiatric complaints as our chief complaint. Because of course we prioritize patient safety and we can standardize this to make sure that our interactions are hopefully amenable and positive. So we also provide them a brochure. I don't have an example of it today, but happy to provide one upon request. But these brochures actually go into how to activate your Epic MyChart. So we provide an educational training in person, but we also have a curriculum that we provide them in the form of the brochure so that they can access this information beyond that encounter. Because we recognize that encounter alone is cross-sectional, but patients oftentimes need reassurance or longitudinal information in order to be able to revisit this to ensure that they can ultimately do what they need to do with regard to Epic MyChart. And then in terms of this, we also do documentation. So we document patients that we've interacted with so that we can keep a track around that. And I'm proud to say that our progress to date, we've already approached 100 patients and over 100 patients in this academic year alone. And over 2/3 of those patients as well have successfully received our intervention. So we hope for that number to keep growing, but we're very excited about the progress that we've had so far. And to wrap up, in terms of next steps and where we go from here, some of this is really important for research. So there's not a lot of pre-existing research. We really are some of the first in class to be able to do something like this, truly through the support of Rush, to be able to approach patients in the emergency department and train them on Epic MyChart usage and increase their activations. So in terms of how we turn this into research so that we can publicize this for other organizations and academic institutions to adopt, we're looking at IRB approval as well as a 118 form exemption as well that will allow us to publish some of this information. We're also going to be looking to target telehealth in the future. So we have telehealth services here, and we want to make sure that patients are aware of that modality, especially because we believe if we can teach them how to use telehealth, it can really benefit some of the patients who have these social determinants of health that might preclude them from coming to Rush for their care oftentimes. And lastly, we want to, like I said, disseminate this and implement this at other institutions. So there's no reason this should only live here at Rush. We want this to be the framework for other organizations and other student-led groups around the country to implement this, ensure that patients really are able to access their medical records and information. So none of this would be possible without these amazing folks here. People make D-Help a success, and I'm only a fraction of that lived success here today. But thank you again for your time in hearing me out and learning a bit more about D-Help as well as patient portals in general. And together we can improve digital health literacy. Thank you.